With that, let's move on to our first speaker, Dr. Katie Voss. Dr. Voss is our program director for our Ultrasound Fellowship, and will discuss bedside echo tips.
Hi, everyone. I'm going to share my screen. Can you see it? Yes?
Yes.
Yes. Okay. Thank you.
Yes.
Well, I'm hoping this will be at least a little bit interactive. I don't know if you guys want to use the chat function on Teams, or you can just talk out loud. I'm fine with either, but we'll go ahead and get started. So I'm Katie Voss. I'm going to talk about bedside ultrasound, specifically in regards to echocardiography. So my goals for this talk, generally, I just want to get you excited about ultrasound. Even if you've never done it before, take it into the room. You'd be surprised what you do learn and things that you do see. We'll spend some time just going over some tips that I have just for general ultrasound and then cardiac specifically. We'll talk about why we want to use it and then go over some cases. And again, I'm hoping it's at least a little bit interactive. This picture on the left is my daughter, but this is what I imagined my face looked like when I realized that I only had 20 to 25 minutes to give this talk, because usually it's like an hour. So I'm going to do my best. So here we go. So general echo tips. So this is my packet of ultrasound gel. This is what we have at Georgetown, and hopefully this is what we have at most places because it's the most hygienic. I don't want you to use this. So this is what I want you to use when you're ultrasounding your patient. So this can be you or the patient, but lots and lots of jelly. So just imagine they're in a bathtub. It really helps. I know we all want to go in and see the patients. We really care what they look like and meet all their family members now that they're allowed in again, but just don't turn off the lights. You can ignore them. Just look at your ultrasound screen. It really helps. Oftentimes I'll find that if residents or students are struggling a little bit, I'll go in and even without moving anything, all of a sudden we can see more. And it's just that I'm pressing a little bit harder. So increase your pressure generally will help a lot. And then I find that frequently people get frustrated when they're looking at the heart. They can't get their views right. They put the probe on and they're just kind of moving it everywhere, which doesn't help. Slow down. Take your time. Oftentimes it's just little millimeters of movements, changing your angle a little bit, and all of a sudden your picture will pop right in. This is my son Theodore. He's 2 months old. But the other thing is, pretend you're a baby or your patient's a baby, put them on their side. So lay them on their left like they're pregnant, and all of a sudden the heart will just pop into view for everything except for your subxiphoid. But for your parasternal images and your apical images, it makes a world of difference. So roll them over, it'll help. Okay, so then the why. So why do I care? Why do I want to use this? I'm not a cardiologist. I'm not an expert sonographer when it comes to complete echocardiograms, but I can do focused ones. So go in with a specific question. So things that, can you guys think of questions that we might want to answer or look at when we do ultrasound? Let's see if anyone talks. Otherwise, I'll just keep going.
What's the EF?
Yeah, what's the EF? It looks like you've seen this before, which he hasn't. But what's the EF? So is it good? Is it bad? Is it in the middle? Can be really helpful, right? Because it's ABEM general or it's the patient's septic and they need their 30 cc's per kilogram, so they're going to get their 7 liters of fluids. Is that a good thing for the patient? Potentially it's not, right? What's another question we might want to look for? Let's say they've got really bad cardiomegaly on their, I'm sorry, someone was talking.
Pericardial effusions.
Thank you. Yeah, so they've got a really huge heart on their chest x-ray and you're like, I wonder if, what is that? Is their heart just huge or is there an effusion there? I promise you guys aren't planted, but thank you for reading my minds. And if there is an effusion, what else might we want to know? Is it tamponade, right? Is it just a simple effusion that the patient's always had and it's not causing any problems? If it is, I don't really care, except that it's cool. But is it causing a problem? If they have tamponade, at least where I work at Georgetown, we don't have interventional cardiologists in-house. I've had a few cases of tamponade and most of those have to get shipped out because the intensivists don't want to take them because they don't have anyone who can do a pericardiocentesis if the patient kind of decompensates overnight or another time. Another question that we might want to answer. So does the patient have right heart strain? This is a frequent one that we'll get asked to look for. So the patient's dyspneic or their legs are swollen or you think they might have a PE, whatever the cause is their right heart functioning? Is it big? Is it small? And then what's their volume status along kind of with the EF? Are we going to give that huge massive fluid bolus? Would that be helpful? Would it not help? Or potentially would it be harmful? So again, we're going to go in with a specific question. I never leave a room and say their echo is normal. I might say their EF looks normal. I don't see a tamponade or effusion, Their right heart does not appear to be strained or pressure overloaded. So again, those are the specific questions that we want to go to answer. So we'll go over some cases now. All right, so case one. So just think about how you're going to manage this patient. You're not going to get much information though. But we have a 38-year-old female who's got near syncope. Our triage nurse is tired, she's overworked. He or she is not putting in a lot of information, so that's all we're going to get. Our vital signs are she's borderline febrile, she's hypotensive and tachycardic, and she's 95% on room air. So it's obviously COVID, but if it's not COVID, what else might it be? I mean, it could be anything, right? It could be pyelo, it could be anything that's causing a fever, who knows? So we're busy. We're gonna put in our orders, or potentially the patient's been seen by MAC3, right? So they are already getting fluids, they're already getting labs, they're getting their lactate drawn. And you're working with 2 medical students. It's a 5 to 2 shift at Georgetown, and one of them is going into cardiology and is very verbose, and you just kind of need a break. So you're gonna say, hey, go take the ultrasound, go into the room, take a look, and you know that that's going to give you a 45-minute reprieve. So they come out 45 minutes later, and this is what they show you. So, this is not like your simple pyelonephritis, right? So this is a parasternal long. So we have the right side, the left ventricle, the left atrium. This is the aortic valve and the mitral valve. So if this was your heart, would you be happy or sad? I'll speak for you. You'd be really sad, right? Like this is a really sad, unhappy heart. Not what you'd be expecting in a 38-year-old, although we're all working in DC and Baltimore, so maybe this is kind of what we're expecting, but not an ideal thing to see. This is another view of that same patient. So this is a parasternal short. So you can see this is the LV cavity here. You've got your papillary muscles. Whoever took this picture did a great job. It might have been myself, I don't know. This is an apical 4. So you've got this left side here, this left ventricle, this right ventricle. You've got your right atrium and your left atrium here. So really nice apical 4. You've got your IVC. So even without measuring it, I'm looking at this and I'm like, oh, it's big, right? I can even see this really big hepatic vein draining in. So this patient's preload probably is not the issue. That's probably not why they're hypotensive. So what are we going to do? Are we going to continue giving our 7 liters of fluids to this patient potentially? Probably not, right? So our medical students saved the day yet again. So we'll talk a little bit about ejection fraction and ultrasound. So some questions that we might want to answer walking in are, so what's this patient's EF, right? Like, do they have heart failure? Do they not have heart failure? Is that why they're short of breath? Should I give them fluids? Should I not give them fluids? Does it matter? So these might be things that you're trying to answer as you walk in. Lots of different methods to look for ejection fraction. And again, we're not cardiologists, or most of us, I assume, aren't cardiologists. There are some fancy methods that we can use called like the Simpson's method and fractional shortening, which require either like a lot of time or software on your ultrasound. So we're not going to go over those today. But the 2 that we'll talk about are just the first one being the eyeball method. So just look at their heart. Is it squeezing well? Is it not squeezing well? I don't really care if their EF is 25 versus 20 versus 30. That's not really important to me. That might be super important to a cardiologist when they're trying to decide if they need an ICD or something else. But for me, it doesn't matter. What I want to know is their EF good or bad or like super good? So let's look at these. So we've got this one on the left here. So remember that your EF is basically your stroke volume divided by your end diastolic volume, or the amount of blood that's in there before it squeezes, right? So if you just look at this, so just imagine you're trying to guess like what percentage of that volume is actually gone between when it's the biggest and the smallest. And I would postulate for this one, it's probably about, I mean, it's definitely more than half, right? So probably like 75% maybe. So this is a normal or maybe even high ejection fraction for this patient. And then compare that, this is the one we were just looking at, this one on the right. So if you just try to guess what percentage of that volume is leaving, then you'll note that it's a lot less, right? So that volume or that cavity space isn't really changing much. So their EF is low. So I would say at least less than 25%. Again, the actual number doesn't really matter to me. Another way, if you do care about numbers and you want to get a better sense, is something called EPSS, or E-point separation. And essentially what this is you take M mode. So M mode is when you take that solid line that goes down the middle of the screen and you can move it around. And essentially once you hit go, it's going to measure movement over time. And you'll get a picture that looks like this. So what you do is you put that line right over the anterior leaflet of the mitral valve. So there's 2 leaflets on the mitral valve, the anterior and the posterior. So you're going to put it right over the tip of that anterior one, and you're going to watch it open here. So this is the mitral valve opening, and there's two waves. So the first one is the E wave, which is the mitral valve opens due to the pressure differences between the atria and the ventricle. And then the A wave, which is it opening a little bit from the atrial kick. But we're going to take the big wave. So just remember the big wave and go to the septum here. And you just measure that distance. There's lots of different numbers, but to keep things simple, the way that I like to teach it is that if that distance there, so the distance between the tip of that wave and the septum is less than 0.7 centimeters, it's really unlikely that that patient has heart failure or that their ejection fraction is low. If it's more than a centimeter, it is very likely that they do have heart failure. And we'll talk about severe heart failure being if it's more than 1.4, but just remember 1. If it's more than 1, chances are that that patient's ejection fraction is quite low. So this is our two methods that you can use just to take a look at the heart to see if it's squeezing well. This EPSS is flawed in a few circumstances. So if the patient has mitral stenosis and their valve just doesn't open, you're not going to get a reliable number. Or if they've got aortic regurgitation and that regurgitant jet is just pushing down on that leaflet and pushing it down so it's not going to open, then you won't get a good number as well. And if you're not sure, take a look at their IVC, take a look at their lungs, get some more information. And more pictures are always better. But that's kind of how we evaluate for the ejection fraction. And I like Carolyn Phillips' comment with the sad face, so thank you, Carolyn. Okay, what's this? Any guesses? I know Carolyn knows this one, so she's not allowed to guess. Or John. But this Darth Vader, obviously, and that's Theodore, my 2-month-old. Okay, so case 2. So we have another 38-year-old female with near syncope. And it's not actually that our triage nurse just copied and pasted, but it's a different patient who weirdly has these same vital signs. So we're gonna, again, want to take a break from our medical student, or maybe our resident's really excited and they're an intern and they want to go look. So they're going to take the ultrasound into this patient. She's already getting her management started by MAC3 or by the triage person who's seeing people today. And our resident walks out and this is what you see. So what's happening with this patient? So what we see here, we have an effusion, right? And so we see a pericardial effusion. And then the question is, do they or do they not have tamponade? And I would say that this patient might, but I don't know. Let's take a look. So this is a peristernal short, right? So we've got the left ventricle here pumping away. This is the right ventricle. This is our effusion, circumferential effusion coming around. Looks a little funny, like the movement of that right side looks weird. So the question is it just weird or is there a problem? Here's one more view in apical 4. This is really what point of care ultrasound looks like, right? It's not perfect. The patient's breathing. You're not going to get a perfect image the whole time, but the image is still really useful and really helpful. So what do you think? Should we keep giving fluids to this patient? Should we cancel our triage orders? Probably not, right? Like fluids actually might be helpful in this patient. So our MAC3 physician did an awesome job. So this patient has a pericardial effusion. So let's just take a minute and talk about that. All right, so an effusion. So fluid on ultrasound is black, right? So it's anechoic, meaning there's no echoes. So what you're looking for is a stripe of fluid surrounding the heart. This is a peristernal long, but you can also do the subxiphoid is really helpful, really any view, but those are my two favorites for looking for fluid. So it's this extra stripe here between the pericardial sac and then the RV and the LV walls. Now, sometimes patients can have pleural effusions and pericardial effusions are just one, and it can be really hard to tell what's what. So use this little guy right here. So this little round, cute little thing in the back of the heart here, that's the descending thoracic aorta. So if the patient has a pleural effusion, so if we have fluid just right here, but it doesn't actually cross over the aorta between the heart and the aorta, chances are that's not pericardial, but it's in fact just a pleural effusion. If, however, like we're seeing on this patient, you see how that
Could you point that out one more time?
Yeah, absolutely. So if you have this fluid right here, if you just look at this black stripe, can you see how this black stripe continues over this descent, over this circle and in between the heart? It's small in this space, but it's there. I don't know if you guys can see it as well as I can on my screen, but you can see that this black fluid, so the anechoic stripe, continues over the descending thoracic aorta. That tells me that that's a pericardial effusion. It's also a good hint that you can see it up here on the right side too. But frequently you only see fluid here, and it turns out that it's actually just pleural and not pericardial. Again, if it goes in between the heart and this descending thoracic aorta, this little stripe right here, then that tells me that it's pericardial. Did that answer your question?
Thank you.
Yeah,
yes,
you're welcome.
Thank you.
Katie, is it typical for it to taper like that to get just a really thin stripe?
Yeah, it is, because this is actually a small effusion. So when we talk about effusion size, you use like centimeter descriptions as to the size of it. But if it's a small to moderate, then frequently it will be small right in this space right here, Manish. But it'll be big kind of on the size. But this is just a more limited physical space in the body, and so it will taper. Now, if it's a huge effusion, there'll be plenty there and you'll still see it. The other thing that sometimes can be tricky is this effusion or is this a pericardial or epicardial fat pad? And sometimes it can be hard to tell because you can have effusions. This one's nice and pretty, right? Like it's just black, but not all effusions are just black. Let's say that this effusion's been there a while and it's exudative and there's lots of like fibrin and strands, or maybe it's infectious and there's pus and grossness in there, or potentially it's like a hemopericardium, so there's blood clots. It'll have echo texture, so it won't be anechoic, but it'll have actual kind of gray texture. One way that you can tell is that if it's epicardial fat pad, it'll move with the heart. Whereas if it's not, if it's just blood clot in there, it'll stay separate. And this is an example kind of that. So this is not my clip, this was Beth Pontius, but this is a subxiphoid. It's hard to tell what's what, but I'll help you by saying that this is the left ventricle here. This is the right ventricle. And all of this is a loculated effusion, which is crazy, but super interesting at the same time. So these are all these loculations. And then if you look back here, there's kind of this goomba here, which I believe this was infectious, if I'm remembering correctly. So this is just kind of pus. But if you pay attention, which I don't know how well you can see it on your screen, but you'll see that it doesn't actually move with the heart, it's separate. So I can tell that this isn't just a fat pad, but in fact, something inside an effusion. So then the next question comes, is this tamponade, right? So you can have an effusion, and if it's not causing a problem, I don't really care, right? It's super interesting and cool to look at, but it's not going to really matter in terms of the acute management of the patient. So how do we determine if there's tamponade or not? Do you guys know? So what we're looking for essentially is whether or not the fluid in that pericardial space is causing a problem with the fluid inside the heart. So if you think about it, the lowest pressure chambers of the heart are the right atrium followed by the right ventricle. So once the pressure or the fluid builds up in that sac, so in this sac here, it's going to exert a pressure. And when that pressure becomes greater than the pressure that's on this right side of the heart, it's going to cause those walls to come in during their diastole, during their filling time, because that's the lower pressure time. And when that happens, then that means that the heart can't fill with blood. And if the heart can't fill with blood, then that means nothing gets to the lungs and much less comes back to the left side. And that's essentially what kills the patient. And we talk about pericardial effusion size, but size here doesn't matter. Oftentimes we'll see these patients that have these huge effusions. And again, they're not causing problems. Because the pericardium is a very fixed structure, but it will stretch, but it'll stretch slowly over time. So if the patient is uremic because their kidneys don't work, or they've got lupus or something else, and they've got an effusion from that, if it builds up slowly, chances are that pressure is not going to cause a problem. But if it happens more acutely, it sure can. And it can happen even with a very small amount of fluid or blood in the heart. So just again, don't say that since the fluid looks small, it's not causing a problem. All right, so we're looking for diastolic collapse like I was telling you. Can you guys tell if this is diastolic collapse? If you say yes, then you're really awesome, because I really can't by looking at this. I know that this is tamponade because it's labeled tamponade in my files, but it's really hard to tell. So this right side looks funny, right? Like it's moving, it's dipping in. It's probably tamponade, but I don't know if that's systole or diastole. So one thing that can really help is if you use slow motion. And this clip is actually already in slow motion because someone with more technical skills than me made it so. But the way that I do it in real life is I'll take this clip. So this was a patient of mine that I saw at Georgetown in February of last year, I believe. And I took this clip and I'm like, I'm at Georgetown. He has an effusion. It's probably not tamponade, right? Because it looks pretty small, but let's slow it down. So what you're going to do is just pause it on your machine and then just move your cursor. And you want to find for when the RV would be in diastole. So that's when the mitral valve is open. This is when the mitral valve is open here. So see this anterior leaflet here, posterior leaflet is right here. So this is filling, this is diastole. Look at this RV wall. See how it's bowing in instead of being nice and round this way or even flat? That's right ventricular diastolic collapse. That's tamponade. This patient had early tamponade, which was a really important thing for me to know because again, I work at Georgetown most of the time and we can't keep these patients here. They have to get flown out. So this patient went to hospital center with his Kaiser physician who funny had already accepted him as a transfer, but then he had a syncopal episode in the ambulance. So they stopped and brought him to Georgetown, which is always awful. So what's this? It's an IVC because it's labeled, but it's also a winky face. That's one of my favorite ones. All right, number 3. We have this same patient, a 38-year-old female, same vital signs, but this time you're going to go into the room with the ultrasound. So your medical student this time is super engaging and awesome. He or she's going into EM. So you don't want to get rid of him. You're going to bring him in with you. And this is what you see. This one is hard to look at. So this was mine, right? So even though I've been doing this for a while, my pictures still aren't always good. But I will tell you that this is the left ventricle here. This is the mitral valve. This is the aortic valve. This is the RV. This is the LA. So what do you guys think? Good or bad? That's the first question I always ask. Good or bad? Probably bad, right? It could be my technical skills. Maybe it's just a bad ultrasound and I should practice some more, but maybe it's bad for the patient as well. So we'll take another clip. So it's a parasternal short. So LV, RV. So it still looks bad to me. We've got another view here. This is me trying to do an apical 4, but it looks like it's actually more of a better view just of a 2-chamber view of the right side. Still a useful picture though. This is a subxiphoid. Looks even worse here. So I'll help you orient yourself. So this is the liver here. So this is the right atrium, the right ventricle. This is the left ventricle here coming into view for a hot second. This is the aortic valve, excuse me, and the left atrium. So again, good or bad? I'm just going to pretend you guys are talking and I'll say, yeah, this one is still really bad. And this is the IVC, always a useful picture with ultrasound. So this is a patient who does have right-sided pressure overload or right heart strain. So different ways that we can look for this patient. And I would pause myself and just say that for that last patient, giving those 3 liters of fluid not only probably won't help that patient, but probably will really hurt her, right? Her right side is already super dilated and exerting pressure on that left side. So probably fluids is the wrong answer for her and she needs some other interventions. So how do we evaluate for this? It's not just eyeball, but we've got some other tools to use. So 1 is a ratio greater than 1. And what I mean by that is that if you take the heart in general, your right side should be about 1/3 of the size when you're talking about ventricular size on an apical 4. So the right side should be about 1/3 and the left side should be about 2/3. Once you get a ratio of more than 1 to 1, then that's considered RV enlargement. Another way that we can look at it is this rule of thirds. So if you take the right ventricle, the aortic outflow tract, the left atrium, they should all be approximately the same size. So 1/3, 1/3, 1/3. And you can see here that that right side is bigger, suggesting that there might be some right-sided enlargement. And then RV hypokinesis, so important one. So what happens if there's an obstructive process distal to the RV, right? So it can't get blood out. All of that blood is just going to sit in that RV. It's going to stretch. And eventually it stretches beyond the ability of which the muscle fibers can actually contract anymore. So it becomes akinetic because it's just too stretched out. It physically can't contract. And this is what you're seeing here. It looks like this heart is moving, but if you actually pay attention to this right side, that volume is not changing, right? These muscle fibers aren't getting thicker and smaller because they're contracting. They're just stretched too far. And then we'll talk about septal flattening. So as that right side gets bigger, it presses down on the septum, which is going to cause it to flatten. And then sometimes even worse, where it actually kind of is pressing in onto the LV cavity here. And when that happens, there's no space for that LV cavity to fill anymore. This is that same process causing what we call a D sign or septal flattening. And then acute versus chronic. So McConnell's sign, this can sometimes in the right clinical context be very specific for a pulmonary embolism. So what happens is that your RV is hypokinetic or akinetic based off of what we just talked about. But you can imagine that a little guy is jumping on this trampoline right here at the apex of that RV, and it looks like it's moving because it's just getting pulled by that LV, causing that bouncing there. That's called McConnell's sign. And then you can look for RV wall hypertrophy. So if this is thicker than 0.5 millimeter, than 5 millimeters at end of diastole, then that's RV hypertrophy. But remember that people with chronic RV failure get acute processes as well as like RV wall MIs. So don't say that just because there's RV hypertrophy, that's not an acute process. So I'll just end by saying that ultrasound is fun. I encourage you all to take it into your bedside with you. You'd be surprised at what you find, and it really can make a difference. Go in looking for something specific, and remember that not everything is just sepsis or COVID these days. Manisha, I have like 30 seconds.
Sure, go ahead.
Thanks. So this is just a cool ultrasound that Rebecca Breed sent me one of our second years. And this is something that they found on ultrasound. And unfortunately, I don't think this patient survived, but look at this clot that's floating on that right side and even in that IVC. And again, this is something you see only if and when you look for it, right? And they did the right thing by getting IR involved, but the patient didn't make it to them. And do you guys know what this is? This is fighting dinosaurs. Do you guys know what this is? I can't tell if anyone's laughing. It's really awkward doing this. This one is Homer Simpson, obviously. We find all kind of fun things in the bladder. So thank you guys. I hope we hit something on the target here. And if you have any questions, feel free to email me. We're happy to get you set up to join our team for some scanning days, and appreciate your attention.
Katie, thank you so much. That was incredible. A ton of information you packed in there in 25 minutes, did exactly what we asked for, so thank you. Again, please put any questions in the chat. We're going to move right into our next lecture, given by another one of our ultrasound faculty, Dr. Jon Watson. Jon is based at MedStar Franklin Square, and he's going to be talking about lung sono pearls.
All right, good morning, everybody. I'm going to work on sharing here. See kind of a blank screen right now.
Yep.
Right. And we got a slide up?
Yep.
Perfect. All right, so good morning, everybody. I'd like to begin with you guys imagining a case. So imagine you're working at your next shift. It's about 4:30 in the morning. EMS calls you over the box and say they have a 60-year-old woman who's coming in with shortness of breath. She's found in her home, very short of breath appearing, hypoxic in the 70s on room air. She looked very tachypnic and labored, so they placed her on CPAP prior to arrival. No additional therapies were given prior to the EMS arrival, and they also state that they're in the ambulance bay now, basically bringing her in. You get her into the room and you obtain IV access. You start assessing the ABCs and you get a full set of vitals. So you know that she's borderline febrile, again, 37.7 Celsius. She's tachycardic in the 120s and regular. She's pretty hypertensive at 190 over 100. And she's tachypnic, and you can tell that she's labored with the respiratory rate that's recorded as 32. And then as you're kind of getting her from the ambulance stretcher to your own gurney, you take her off of the CPAP or positive pressure briefly. She does desaturate to the 70s on room air, but you're able to get her adequately oxygenating with positive pressure ventilation on 100% FiO2. You're able to get a fairly limited medical history from her, based on the acuity of her condition, and you discover that she has hypertension. She has history of COPD, so on a couple liters of home oxygen. She has history of CHF, unknown exactly what her ejection fraction is. She also has history of DVT, and not sure exactly, if she's been compliant with her NOAC. Unfortunately not the greatest historian, but you do note through the chart review that she has history of spontaneous pneumothorax in the past with apical blebs that are present from her COPD. She also says that she has a history of fluid in the chest. She's not sure exactly where, if this was her heart or lungs or what, but says that something had been drained in the past. And of course, she has not received the COVID vaccination. So you start to build a differential diagnosis in your head, and you realize the list is starting to get pretty extensive in this patient, right? Does she have hypertensive emergency with flash pulmonary edema? Does she have acute decompensated congestive heart failure? Is this just COPD exacerbation? Does she have a PE, with her history of the DVT and not sure if she's on the NOAC? Does she have COVID, or is it just regular bacterial pneumonia, community acquired? Does she have pneumothorax from her history of COPD and these blebs? How about pleural effusions? What about ARDS? What about ACS? The list starts getting very long. So in order to help you narrow down your differential, you try and listen to the patient, right? Take your stethoscope out, but you realize you're having trouble getting a clear exam. There could be a lot of reasons for this, right? You have 3 or 4 nurses in the room, tech, getting blood work and trying to get the patient situated and draw labs. You have the monitor alarming because of the abnormal vital signs for the patient. You have the CPAP or BiPAP machine that's creating a wind tunnel in the room from a poor mask seal. Or maybe today is just the day that you forgot your nice Littman cardiology stethoscope at home, and you had to borrow one of those really high quality yellow C. diff isolation stethoscopes. But for whatever the reason, you realize that your auscultatory exam is not really as helpful as you'd like it to be, and you really can't tell the difference between a wheeze and a crackle. So you need help in order to help narrow down your differential diagnosis. So of course you're going to call for chest x-ray. So the x-ray tech answers and says, yep, no problem. We're just finishing up an ICU rounds because it's about 5 o'clock in the morning now. We'll be done in about 30 minutes or so. So now you're kind of stuck with this patient, right? So I'm hopeful that this talk will teach you the advantages of another skill that you can use to help diagnose and treat this patient that I think emergency physicians can easily learn and perform at the bedside. So of course I'm referring to lung ultrasound. And specifically bedside ultrasound. So let's figure out how we can use it to help this patient and many others that present to the ED with dyspnea. So again, my name is Jon Watson. I'm an attending physician at Franklin Square Hospital and part of the MEP division of ultrasound. Thanks to Dr. Goyle and Davis and the planning committee for having me. So the topic of lung ultrasound, while in this 24-hour news cycle, it may not be considered breaking news, it still is a fairly new modality. The first application of lung ultrasound was actually described in 1995. So thinking in the grand scheme of medicine, back to Hippocrates, it still is fairly new. So for this reason, many clinicians may be unfamiliar with the utility in ultrasound for lung imaging. But hopefully we're able to change that a little bit today. So the reason why lung ultrasound is different than ultrasounding most other organs that you may be familiar with is that what we're going to be doing is actually analyzing artifacts the entire time, just like Indiana Jones is doing here. So remember Katie Voss, I told you that you want to use a lot of gel and pressure. And the reason why we're doing that is to avoid any air that's getting in between the probe and the organ of interest. And ultrasound waves cannot travel well through air, and they kind of get scattered and then don't create an image. So obviously this poses a problem when you're trying to image an organ that's full of air. So we can actually use the analysis of these artifacts to help us differentiate between multiple pathologic processes. So let's get started. The first thing you're going to need to do is choose the right probe. And just as a review, kind of in basic physics, there's 3 main probes that you're probably familiar with. Starting on the left here, we have the curvilinear probe, we have the linear probe, and then this is called phased array. So each probe has its own properties, and one of these properties is the frequency. So the highest frequency probe is going to be typically the linear probe here in the middle, which is going to provide the highest definition or highest quality image that you can create. But the trade-off with that, there's an inverse relationship between the frequency and the depth that the ultrasound beams can penetrate. So, and that's due to the attenuation of the ultrasound beam. So you have very high frequency, you can't really go down very deep. Only I think maximum of 7 or 8 centimeters on some probes of this linear. In contrast, if you were to use the curvilinear probe, which has the lower frequency, you're able to get much higher depth penetration. So for ultrasound, we're actually going to kind of use a combination of these two depending on what you're actually looking for specifically. So if you're looking for something more superficial, like we're going to start with looking at the pleural line specifically, you want to use the linear probe to get started, but then you may want to switch to something like the curvilinear probe if you're searching, if you see a pleural, abnormality and think that there may be an abnormality of the lung there, and you want to look deeper down into the lung tissue, you would use curvilinear. So to get started, the first thing you're going to look for is the pleural line. So to do this, remember with ultrasound, you're going to use your probe marker, and you're going to always, the standard is to position it either towards the patient's head or towards the patient's right side, and that's a little knob on most of the ultrasound probes, and that correlates to the indicator marker here. So we have the orientation, the patient's head up here, and the feet are going to be down here. And when we put the probe on the chest in this kind of longitudinal orientation, you're going to start to see you're going to be looking for the pleural line. And the landmarks we're going to be using are the rib shadows that are created. So here, we have the skin, we have the subcutaneous tissue, we have down here a rib. So you have this bright hyperechoic area here, and another one kind of off to the side here, and they cast a shadow down, right? There's not really any image that's created. It's all hypoechoic, posterior or deep to that. And that's because the ultrasound waves can't penetrate through bone. So in between the two ribs, obviously you're going to have the intercostal muscle, which is here. And then just deep to that, you're going to have the pleural line. So the pleural line is this bright hyperechoic structure here, which is created when there's basically the interface between soft tissue and air, okay? And it's created, there's just called it like, this is an artifact, it's an impedance difference between those two, kind of the two waves that they transmit sound waves. So when the ultrasound comes down and it hits the pleural surface and there's adjacent air, either from a pneumothorax or just normal aerated lung, the waves are reflected back to the ultrasound machine and no true image is created deep to the pleural line. So this normal aerated lung just mostly looks like static. This is not truly like, you're not actually looking at the lung, you're looking at the artifact that's created from this reflection here. So when we're looking at the pleural line, this is the same image. This is a normal, healthy, pleural line in healthy lung tissue, and it's described as kind of having a shimmery or like an ants on a log or ants marching appearance. People describe it as. So if you focus your attention on this pleural line here, you see that as the patient breathes, you can see it sliding left and right, which is kind of like up and down in the patient, and it has the appearance of kind of like 1,000 ants that are marching along this stick or this log that's here, which is the pleural line. So this artifact is created when the parietal and visceral pleura are attached to each other. Okay, so you will see lung sliding. So when the chest wall moves, the lung moves with it. But the absence of lung sliding can indicate that there's a pneumothorax because there's air that's present within the two layers of the pleura, and you won't see this normal artifact. So let's move over to the other lung and say that there's a history of chest wall trauma or the patient had a rib fracture. So again, we're going to focus our attention on the pleural line. So to get our orientation again, it's the same as before, probe marker up towards the patient's head. This is their head up here, feet down are this way. And then we can see again, we get our bearings. We have a rib here with the shadow behind, rib here with the shadow behind. We have the intercostal muscle, and then just deep to that, we're going to have the pleural line. So if you contrast this line to the kind of the ants marching appearance or the shimmery appearance, you see that there's not really that same pattern here. And when the patient breathes, you don't really have that normal kind of to and fro appearance of the pleural line. So this is suggestive of a pneumothorax. So it's highly, sensitive for a pneumothorax and actually more sensitive for occult pneumothorax than a chest X-ray. But there are some cases when it can indicate something else, such as an ARDS with very poor compliance. So the lung, is not expansive very well with each respiration, but it is very sensitive, not the highest specificity though. But we'll see something that's a little bit more specific for pneumothorax as well. So if you're not sure exactly if there's lung sliding or not, you can, or you want to prove it to yourself, you can put on M mode. So remember that M mode stands for motion, and you're analyzing motion along a certain line that you create. So you get this, your regular image, you have, again, rib shadow here, rib shadow here. Now we're using a curvilinear probe. Just you notice the different footprint, and they're getting a little bit deeper image, which is, you know, another way to do it. This is fine. So we see the pleural line here, and we're putting the motion in like analyzer through the pleural line, and it's going deep down. And on our graph here, what's going to be created is a graph of motion over time. So the x-axis is time here, and the y-axis is kind of the depth. So the first, you see in the first kind of quarter here, it's most superficial to the skin, there's not really any movement. And what you see is this kind of repeating linear pattern. And then as you get to the area where the pleural line is, there's a transition in that artifact, right? And it creates this kind of speckled, sandy appearance. And this is what's called the seashore or waves on a beach sign. So this is good, right? You remember you always, good to be at the beach. So you imagine yourself kind of on the beach in the sand, kind of looking out in the horizon, and you see these waves that are coming in, right, through the horizon, and this is the seashore here. And it reflects that there's a change in the motion pattern between the two. We can contrast this to the barcode or the stratosphere sign when you have a pneumothorax or absent lung sliding. When there's not that change in the movement pattern, you see that it's basically looks like a barcode all the way down, right? And this is suggestive that there's no lung sliding. So if you see absent lung sliding, you know, that's pretty highly suggestive of a pneumothorax. Not 100% sensitive, but what you can look for that is 100% specific and pathognomonic for pneumothorax is something that's called the lung point sign. So you see here we have the same orientation as before. We have the linear probe now, and we have the pleural line. You see that kind of, this one is a little bit a regular side appearing pleural line, but you see this bright hyperechoic line, and then with movement or with respirations, it's moving side to side. So that's normal movement. But then if you contrast that to the right side here, you don't see that ants marching appearance or the lung sliding on this side. So this is the exact point actually where the lung is becoming detached from the chest wall and is pathognomonic for pneumothorax.
Hey, John.
Yeah.
Dave Hager here. Quick question. The barcode sign, you had indicated that sometimes the ants on a log sign that you pointed out could be seen with other conditions other than pneumothorax, like ARDS, for example. Is that true of this barcode sign as well? Can you see that with ARDS, or is this more specific for pneumothorax?
Yeah. So there are some other things. This is not specifically, it's not specific as to pneumothorax. With ARDS, though, you're going to see some other signs. Like B lines, which we'll get to, which is indicative of, you know, pulmonary fluid. So these lungs overall look dry because you see, we'll see, you actually see some A lines here as well, which is another finding we'll get to in just a couple minutes. So this pattern is kind of more suggestive of a pneumothorax, but if you had something like ARDS, for instance, you may see the same, you're not going to have that normal lung sliding M mode pattern, but you may also have some other features like B lines, which are going to be these common-tails that go down, and absence of the normal A lines. So it's a good question. So what I'm showing here is, thought a pretty interesting case is, remember the lung point we see, if you look first on the right side of this image with a zoomed in view of the pleural line, you see this ants on a log appearance, ants marching appearance, and on the left side we don't see that, right? So this is actually a live image when they're putting in a chest tube, and you're seeing the resolution of the pneumothorax in real time. Just thought that was pretty cool. All right, so the next one I had mentioned is kind of the A lines and B lines, which are other artifacts that you may see when you're looking for the pleural line. So A lines are typically indicative of a dry, well-aerated lung. So you can see this in findings for pneumothorax because the lungs are still dry, right? You wouldn't see the normal lung sliding, but you don't have a bunch of fluid within the lung. So the A line's created when the ultrasound beams are coming down and they hit the pleural line and they get reflected up. Okay, and all this deep to the pleural line, remember, is just artifact. It's not actually looking at anything real within the lung, but it confuses the ultrasound machine because the waves come down and they beam back up, and then the waves can reverberate between the probe and the pleural line, and it creates this repeating pattern going down. So each one of these, you notice, is kind of equidistant as it is from the chest wall. You create these horizontal lines that are called A lines that come down. In contrast, we have B lines as well, which also are artifacts that are created when there's internal reverberations within the interlobular septa and creates this comet tail appearance of reverberation artifact. So A lines are, remember, healthy aerated lung. B lines are indicative of pathology, typically. So let's examine B lines a little bit more closely. So in order to call it a B line, they have to originate at the pleural line. So we have the pleural line up here. Now we have the curvilinear probe. We're actually seeing multiple rib spaces, right? You can see a rib shadow here, here, here. So this is like four rib spaces, excuse me. And we have the bright pleural line with the comet tail artifacts that are coming down, called the B lines. They go all the way down to the bottom of the screen, and with respiration, they move. So you can use these B lines, obviously for diagnosis, right, of pulmonary edema, but it also, it can help you with your differential diagnosis. And in one study, they had noticed in ICU patients, they had 100% of patients that had acute decompensated heart failure had B lines on their ultrasound, whereas patients with COPD, 92% of them did not. So there is a pretty good, correlation between the disease processes. So you can also use this as a response to therapy and the severity. So more B lines means more fluid typically, and they've actually done case, analysis of like dialysis patients that are going through dialysis that have had volume overload and pulmonary edema. That actually through the session, you're able to see a decrease in the number of B lines that are present in real time. So the presence of these B lines is not necessarily specific for acute decompensated heart failure, because you can see these B lines we'll see in pneumonia, high altitude pulmonary edema, ARDS, etc. But if you see diffuse B lines kind of everywhere, and in the right clinical context, right, it's very suggestive for acute decompensated heart failure. And to say that you're going to have diffuse B lines, usually bilaterally in like 2 or more regions of the lung. So kind of like anterior superior and anterior inferior, or lateral posterior, for instance. Okay, so I'd encourage you, even if you're not using this primarily to aid in your diagnosis, just put the probe on your next patient that has heart failure. If they have congestion on the chest X-ray or pulmonary edema, put it on. You'll see this. I think it's pretty interesting. So these are the 4 kind of areas of the anterior lung that you would scan. Remember, I said that you'd see diffuse B lines. So you want to scan all over the anterior chest, and the areas are divided by the parasternal line here on the left, on the patient's left, the anterior axillary line, and the posterior axillary line. When you're scanning that, you may see some other features that weren't notable when you're looking at the pleural line at initially. So you're going to start with the patient supine, right? And you're looking for pneumothorax, and you're looking at the most anterior part of the chest wall, because that's where any free air is going to accumulate, right, to the least dependent portion. But when you're doing a thorough lung ultrasound, you may find some other areas that are focal, right? Because a lot of pneumonia may be focal. So what we're going to focus on now is actually pneumonia. So there are a couple findings on this ultrasound that I'd like to point out to you. So the first off is what's called the shred sign. So again, we're looking for the pleural line, and we don't see a nice crisp pleural line in here, right? We see this kind of bright hyperechoic area, but it has this like shredded or kind of ratty appearance here. And you see, if I trace the pleural line, it comes down, and then here we actually have this consolidated area. You see how it just kind of looks ragged and shredded up. So this is called shred sign, which is indicative that there's like pleural thickening and nearby consolidation. There are a couple other features that we see. Remember, we were talking about B lines, and you see some B lines that are here adjacent to this consolidated area here, which are these bright hyperechoic lines that are shooting down, which is indicative that there's fluid that's accumulating in the alveoli that's near this consolidation. And if you look at this area, right, this is actually the area of the consolidated lung. It kind of looks a little bit like the liver, right? So if you do fast exam, this is kind of the same or similar appearing echo texture as the liver. And this is a finding that's called hepatization of the lung, or the lung looking like liver. And that's indicative that there's consolidated lung, that air is not getting through very well. And there's another feature on here of these. You see that it's kind of this bright speckled appearance in here. These are called air bronchograms. So we'll get to that a little bit more. But basically, it shows that there's air trapped within the consolidated lung. And then we also have a little bit of a effusion as well that's present. You see this hypoechoic area or anechoic area. This is another example of a shred sign. We see the pleural line. They're using a phased array probe, which is not my favorite really to use for ultrasound of the lung, but you can still do it. But we see this irregular kind of shredded appearance of the pleural line here, which is indicative of nearby consolidation. And then there's air bronchograms, which remember are these hyperechoic speckles or tubules that are present within this consolidated lung. You see, again, it looks like the liver, right? But we're above the diaphragm. You see the diaphragm here, I'll trace here. So this is the diaphragm. And then we're above that, so this is the lower lobe, I guess, on the right side. So there shouldn't be anything that looks like the liver in the chest wall, but this is the lung that's all consolidated. And you see these air bronchograms, and this is a good example of what's called a dynamic air bronchogram. So focus your attention here, and you start to see how this level of air is kind of moving up and down with respiration. So this is actually reflecting air movement within this consolidated lung. Okay. So this is called actually a dynamic air bronchogram. And here's another example of a consolidation. You see, again, looking at the lung, something that looks kind of like the liver, right? Same thing here, looks like the liver. And you see these bright hyperechoic lines, and they're dynamic as well, meaning that they're moving with respiration, which is highly suggestive of a pneumonia. So you continue scanning, and you're going to look in the posterior and lateral areas of the lung as well, kind of going towards the more dependent regions, and you may see pleural effusion. This is what's called the jellyfish sign. It kind of looks more like a starfish, I think, to me, in this picture at least. And this is consolidated lung that's kind of swimming in free fluid. So we see that we're above the diaphragm here, right? So we see the diaphragm. This is a rib shadow that's casting down. We have the diaphragm here, this bright hyperechoic line, and then the probably the spleen here in the left lower lung. So we see this pleural fluid here, anechoic, and the consolidated lung floating in there. You can see also the air bronchograms that are present that are suggestive of a pneumonia. So this is kind of a atelectatic or pneumonia lung with floating in pleural effusion. Remember that this you won't see if you're just going anteriorly. So I encourage you to bring your probe out kind of posterior laterally at the most dependent region without rotating the patient, because if you rotate them, the pleural fluid is going to rotate with. This is another example of a kind of the jellyfish sign for pleural effusions. You see that you have the diaphragm here as well, this bright hyperechoic area. This is either the spleen or liver. I'm not entirely sure because I can't see enough of it and don't know if we're on the left or right. But you see that you also have some intra-abdominal fluid, right? So this patient probably has ascites and like volume overload. So you see a little bit of free fluid underneath the diaphragm here. So, but then there's a large amount of pleural fluid. So you can use, when you're doing a thoracentesis, I'd encourage you to also use ultrasound to help at least find your spot, make sure that there's a safe enough, pocket for you to hit. And you can actually use a dynamic to actually watch your ultrasound or excuse me, watch your needle go directly into the pleural cavity. You may see also, the other examples were of, simple fluid, probably from volume overload, but this is an example of malignant pleural effusion. So you see all these internal septations. This is all pleural fluid that may not be easily drained kind of with a regular standard pigtail or catheter. So you may be asking yourself, isn't that what X-ray and CT scans for? That's why we, that's what we usually do to look at the lungs. But I understand, this may be new to you, but may not be part of your normal practice. But I do think there are several advantages to using ultrasound. First off, it's cheap, right? It's a fraction of the cost of X-ray or CT scan, especially. It's fairly easy to do. I think with dedicated, practice and doing this on a few patients, you can pick it up pretty easily. It's pretty easy to get your views as well. There's not anything really complex. You just put the probe on the patient's chest wall and you'll see the pleural line there. There's not really anything to get in your way, as far as like body habitus for most people or anything like that. It's portable. You can use this even a handheld device or small devices we can use at the bedside, so the patient doesn't need to leave your emergency department to go to radiology. And it's patient satisfier, I think. Probably one of the biggest complaints is the patients have is, the doctor didn't really spend any time with me, right? You may complain that this takes a few minutes, right? But this will keep you at the bedside and gives you more time with the patients that they really want. And you have more chance to, talk with them and kind of be with them. It's safe as well, right? There's no chance of iatrogenic injury like there is with, contrast from CT or radiation exposure. You can use this in a noisy ED. It doesn't depend on you hearing anything. And sometimes people describe lung ultrasound as the new stethoscope. And I think importantly, you get immediate answers, right? There's no delay in transport. You don't have to wait for the tech to be available. You don't have to wait for them to load the images in packs. You don't have to wait for the radiologist to interpret the image. You know the answer pretty much right away, okay, while you're at the bedside. You can do live, data, acquisition and interpretation at the same time. So that's all I've got. I wanted to share a few resources with you that I think are very helpful in learning this. There's two. There's one that's called Core Ultrasound. If you look up, it's by Jacob Avila, who's one of the big names in ultrasound. There's a series called 5 Minute Sono. So if you need a refresher at any time on lung ultrasound or really anything, it's got really brief 5-minute videos that are very thorough but concise at the same time. And then there's the POCUS Atlas, which I got a lot of the images from, which is kind of an open source, database for interesting ultrasounds that people can submit. My email's here. If you guys have questions now, I'd be happy to take them. Or if you would like to email me, I'd be happy to answer your questions over, lung ultrasound or really anything in general. Thanks for your attention.
Jon, thank you. That was really excellent. Just for any interest of time, we'll hold any questions. This is a great opportunity to whet your palate for how valuable ultrasound is to your clinical practice. In addition to the resources Jon put up, consider the weekly review that Dr. Carolyn Phillips leads, and I know that there are other ultrasound-based options for growth in our department. Let's take a 5-minute break. It's 11:03. We'll come back at 11:08. All right, looks like most folks are back. Let's go ahead and get started with our last lecture for our fall symposium. Dr. John Davis, Academic Chair and Professor of Emergency Medicine here at MedStar Emergency Physicians, a lecture that he often delivers to the residents and gets rave reviews, so I'm excited to see it. Jon, thanks for joining us.
Great. Well, thanks so much, Manish, and really great to see everyone. The title of this talk, very aptly so, is Treachery is Always in the Detail. And I can tell you that everything that we're going to cover in this talk, 5 cases strong, is predicated on a pitfall that I have stepped into at some point in my career as an attending physician. So we're going to talk about things specifically in the MSK realm in terms of critical radiology. So our goals and objectives, quite simple. globally to avoid getting stung by common radiographic misses in the MSK domain. And then specifically, we're going to try to infuse some practical pearls, avoidable pitfalls, and then most importantly, when it comes to interpreting x-rays, a very regimented approach. And so we're going to cover some things that you practice on a regular basis, but we're really going to focus on that regimented approach to really recalibrate on it. So the roadmap, how we're going to cover the next 50 minutes, we're going to start with the why, the what, the wow, a few bonus cases in there as well. And as I said, all of these cases are pitfalls that I have made at some point in my career, hopefully don't continue to make. That's the reason that we're here. So the real goal is something for everyone. And those who know me well know I describe everything as a Starling curve. Like almost everything in life can be described as a Starling curve. So we're going to start off with case number 1, which is really straightforward, but it's a good reminder for all of us. Case 2 is going to be some subtleties that are really easy to miss in pediatric musculoskeletal injuries. But then cases 3 and 4 are the real risky cases. These are cases that I've curated over the last 20 plus years. Some were from the time I was on the West Coast, some were from the time here on the East Coast, but really important points and cases that were missed by exceptional attending physicians. Really easy to step in these, and we want to learn from those cases to avoid similar pitfalls in the future. And then finally, case 5 is really focused on the latest literature and making sure that we're speaking the language of our consultants. So we'll jump into case number 1 here. So case number 1 is a 12-year-old male, basketball injury, comes in with finger pain and tenderness. Now, feel free to use the chat function. I have the chat function pulled up on my iPad right next to me. Also, feel free to come off a mute, but just what jumps out at you when you look at this x-ray? Anything jump out at you? Just feel free to put it in the chat. Feel free to say it off of, come off a mute. Look at this x-ray here. Anything jump out at you? We'll get a little bit more specific. This is the area where the patient's tender. So anything jump out? I'll tell you what jumps out to me is I see growth plates. So this is going to be the first point that we're going to talk about. Any x-ray that we take where there's the presence of growth plates, we need to think differently about that patient. And the reason for that is this whole growth zone and as it pertains to Salter-Harris type of injuries. Now, I saw this when I was a first-year attending working at a community ED. I had a patient who was complaining of pain. There was the presence of a growth plate. And at no point in my training did I have that regimented approach that whenever I see a growth plate and there's tenderness over the growth plate, the answer is to always splint, follow up with orthopedics or sports medicine. That's always the answer. It's kind of like, I recall this time during residency when we had a patient with acute urinary retention. I was an intern. One of the senior residents just said, oh, this is easy. Foley, leg back, urology follow-up. Bam, easy button, 3 quick things. It's the same thing whenever we see a potential growth plate injury. At a minimum, if it's tender, we're going to call it a Salter-Harris type 1 injury, but it also could be a more significant Salter-Harris injury that we need to be on the lookout for. A lot of confusion about, well, which one's a 2 versus a 3? The way I think about it is at the center of the bone is where all the good stuff's happening. That's where all the turnover is occurring. So if I'm closer to the center of the bone, i.e. type 2, that's where my injury is, the more likely it's going to repair itself. It's no different than us fixing a facial laceration in a small child. There's a lot of plasticity. It's going to most likely heal really, really well compared to some of our more senior patients that we fix facial lacerations on. So really important to remember that type 2 are more proximal to where the turnover is occurring. Type 3 are more distal. Type 4 is when it includes both. And type 5, which is probably the worst, is a crush injury where you really ruin that area of growth where the bone elongates. So case 1, simple reminder, 12-year-old basketball injury, finger pain and tenderness. The pearls, kids don't get sprains. They can get sprains, but we need to, from an emergency care perspective, presume it's a Salter-Harris 1 fracture until proven otherwise. So every time we see a kid that has a growth plate, it's tender over that growth plate. Even before I get the x-ray, I have that conversation with the child and with the parent that at the end of the day, you're going to be leaving here with a splint. We're going to send you to orthopedics. We're going to send you to MSK. They'll take off the splint, they'll mash on it. They may choose to do an MRI or more advanced imaging at that point, and they'll make a decision whether to continue with splinting and or cast for the next couple of weeks. So never forget about that Salter-Harris 1 injury. And if those growth plates are present, it's a rule out SH1 until proven otherwise. We often see patients in chairs in the hallway, ED crowding. We know it's part of our world. Level 4 visits can still have significant injuries. This is a photograph of an x-ray that was taken many years ago, but you can see initially called perhaps a shadow. I'm not sure what that is in that radiograph, but the follow-up CT showed that it was a clear-cut fracture, so a Salter-Harris 3 type of injury. We're going to talk about CT imaging and how that can help in some thorny cases when you're really not sure what's happening, and we'll talk about that a little bit further. So our Salter-Harris type of injuries, just to review, an important thing for us to know, again, speaking the language of our consultants, whether it's through the growth plate, which could be really hard to identify because it's within a growth plate, it's in a line of bone already, a gap that's already there, and then it advances, and the further you get away from the center of the bone where the good stuff is happening, the more significant the injury, and of course, crush injury is always the worst. So a quick safety check, and this is going to tie into something that we're going to talk about in a few minutes. So pediatric sedation, something that we talk about, not necessarily related to MSK, but then again it is, because what happens when we have fractures that need to be reduced? We often need to provide some type of sedation to put that bones or those bone fragments back in place. So what is the IV ketamine dose for a 3-year-old? So don't have to call it out, but we need to know roughly how much a child weighs. And we can rely on what we see in MedConnect and Cerner, but we can also do that safety check with the rule of weights. And this is a common pitfall, a common error that we see, especially whenever there's scales that can both obtain pounds and kilograms. So the way I remember it, something that I was taught in residency, neonates are around 3.5 to 4 kilograms, 1-year-olds are around 10 kilograms, 3-year-olds, 15, 5-year-olds, 20 kilograms. I have committed this to memory. I'm not a huge fan of committing too much to memory. I like to have peripheral brains to look things up, but this is something I always keep in mind. If we get a call from EMS that a seizing 3-year-old is coming in, I look for the Braslo tape. I can't find it immediately. I at least know, directionally speaking, that that 3-year-old is going to be somewhere around 15 kilograms. This becomes important when we're seeing kids in the ED setting. If we see a 3-year-old that weighs 30 plus kilograms, what's the error? It's most likely that their weight is actually a pound weight that wasn't converted to kilograms. Another thing to keep in mind is that at around 5 years of age or 20 kilograms, there tends to be a leveling of pediatric and small adult dosing. So look at typical things that we order. Ceftriaxone, 50 mg per kg. Well, what would we order in most routine circumstances in terms of ceftriaxone for an adult? It'd be a gram dose. But in a 5-year-old, 20 kilograms times 50 mg per kg is a gram. So oftentimes when you get beyond 5 years of age, 20 kilograms, you start getting into supra adult doses. We have the advantage of often seeing adults as a primary and probably the more predominant part of our practice. Always compare it to the adult dose. There's a handful of medications which kids chew up and metabolize in a very different form, but I always like to know what's the comparison with what I would give an adult. Another example of that is morphine, 0.1 mg per kg. Some of our colleagues may disagree with this, but I believe that morphine comes in 2 varieties, 2 milligrams or 4 milligrams for adults. The reason I say that is because during my training, I worked with an attending at one of the shops where I worked, many shifts with him. He was a nocturnist, an exceptional doctor, but he truly believed in 0.1 mg per kg on every patient that required analgesia through an IV. The problem was at the end of the night shift, we could never disposition anyone because everyone was snoring. So it's a lot of medication in my mind. So I've stuck with the 2 in the 4 milligram. But think about it. If you have a 5-year-old, 20 kilograms, 0.1 mg per kg, you're already up to a small or typical adult dose. So something important to keep in mind. And we're going to get back to that point as we move on. So case number 2, a little bit more complexity here. 5-year-old female, fall from the monkey bars at a park, complaining of arm pain and tenderness. So images are ordered. First and foremost, we see a child, we see a fall, We see an upper extremity injury. We're worried about a couple of things. At the end of the day, if they're tender over a growth plate, we know that they're going to get a splint and they're going to follow up regardless of what else the x-ray shows, but it could be something more serious. So let's look at this elbow here. So we're going to go over the approach to really evaluating this x-ray. Does anyone want to call out? Anyone see a fracture here? It's really, really subtle. This is a case that I had a couple of years ago. Really, really subtle injury here. So let's look at our approach to evaluating this x-ray. First and foremost, when we're evaluating the pediatric elbow, we always want to look at the lateral. The lateral is the key study. We look at the other ones as well, but the key dimension that we're looking at here is the lateral view. And we're looking for that figure of 8. Is that figure of 8 present? Next, we're going to look for the presence of fat pads, anterior. Now, you can have a little bit of fluid there anteriorly at baseline, but we're really looking for a bowing out or a sail sign anteriorly, and there should never really be much in the way of fluid posteriorly. So everything that's posterior is abnormal. Next, we're going to look at a couple of different lines and see if they line up with the capitulum. The capitulum is this bone that you see right here. So we're going to look at that anterior humeral line, and we're also going to look at the mid-radial line. And by and large, they should intersect right at the center of the capitulum, but no further than somewhere in that middle third of the capitulum in both dimensions. So looking at this particular x-ray, here's a cone down view, really subtle injury, but it's present. And if we go back to this view, we can see the fracture pattern there, supracondylar fracture. The key thing to remember about supracondylar fractures, they can be really subtle. So important thing to keep in mind when we're evaluating the pediatric
Hello?
elbow. Looking at
Hello?
Thanks so much for joining. And so looking at this view, we're going to go ahead and see if we can see the fracture. This is the same elbow as before. I'm going to put the line there. I'm going to move it away. I'm going to put the line there. Now I'm going to put an arrow, and I'm going to remove that line. Really subtle injuries. The important thing to remember, supracondylar fractures can be very, very subtle. Here's another case. So what do we see here? Do we have a good lateral view? Yes, we see that figure of 8. Do we have abnormal fat pads? I'll go ahead and remove those so you can see them again. We see a hyperanterior, a sail sign, always AB normal. We see presence of fluid posteriorly, always abnormal. We look at the anterior line for the humerus. We look at the mid-radial line. They do indeed bisect the capitellum. This is important for other reasons, but no question there's a fracture in this one just by virtue of seeing those fat pads. So here's the fracture on this next radiograph. A couple of more radiographs here. Again, illustrating these same points. Do we see a figure of 8? Is it a good lateral? Looking at that anterior humeral line, also looking at that mid-radial line, does it bisect the capitulum somewhere in that middle third in both dimensions of that bone? A couple of abnormal images here. One, you see that the anterior humeral line is bisecting the capitulum, not in the center, but off center. So it's the 1/3 that's in the front portion there. So that is not an appropriate alignment. We do see a posterior fat pad, but we do see normal alignment when we look at that mid-radial line. This x-ray, not very subtle, the abnormality that we see here, but let's look at it through our routine process. Do we see a posterior fat pad, which is present? Let's go ahead and look at those lines. Nowhere near the capitulum. So an easy way to tell that there's an issue with this fracture. So looking at this radiograph, what is the problem with this x-ray? So going back to the principles that we talked about before, first and foremost, we want to look for a figure of 8. That's the first thing we do whenever we see a lateral. Kids who are in pain, sometimes it's really hard to get the images and get the movement in the elbow that the radiology techs need to capture the images. So the problem with this is we don't see a figure of 8. So all of the rest of our metrics, whether we're looking at anterior, posterior fat pads, whether we're looking at those lines and bisecting the capitellum, make no sense because it's not a true lateral film. So case number 2, the things that we have to remember: 5-year-old female, fall from the monkey bars, arm pain and tenderness. The pediatric elbow is an area of treachery. Kids think supracondylar. Adults, think radial head. Because just like supracondylar injuries in kids, radial head injuries, we all know from practice, can be really, really subtle. I personally find that a really helpful thing to document is pronation and supination in the absence of pain when pronating and supinating, because from experience, I can tell you that when there's significant pain with pronation and supination, even if your x-ray is normal, the chances of having an occult radial head injury are fairly high. So pronation and supination are really helpful exam adjuncts, particularly in our adult patients with normal radiographs. So what are our rules? Again, our goal here is to come up and remind everyone of the regimented approach to all these radiographs. First and foremost, step one, is it a good lateral? Is the figure of 8 present? Is there an hourglass? Number 2, is there a fusion? Posterior is always AB normal. Hyperanterior is abnormal. That sail sign, you can see the photograph of the sail. Whenever we see something like that anteriorly, that is always abnormal as well. What are the lines? Whether it's that anterior humeral, that mid-radial, should be bisecting the capitulum. And finally, breaks, scouring for fractures. Showed a couple of examples here where you really have to scour the x-rays looking for those fractures. But the real question for us is when to call. When do we actually have to get a consultant into the ED when we're faced with this scenario? You can see the image here, clearly posterior, clearly anterior, that anterior humeral line nowhere near the capitulum, but do we splint and follow up? Or do we need to get this person in to see an orthopedist sooner than that? And this is the Gartling classification, which is really helpful. Again, speaking the language of our consultants, it helps guide us in when we cast versus when we need to engage our consultant in real time for consideration of reduction in pinning. And it's all about distraction and or displacement. You can see in the higher grade Gartland injuries, there's distraction and or displacement of the distal fragment or the distal portion compared with the proximal. And that's when the orthopedists are really getting in and doing something. But regardless, in the setting of a supracondylar fracture, it is best practice for a phone touch base with your consultant. Tell them what you see, have them look at the radiograph, come up with a shared decision. So a little bit more on PEDS x-ray. So one of the things that we talked about before, so looking at this radiograph, we've trained our minds, we see growth plates. At a minimum, we know this child is going home with a splint. Why? Because we're getting an x-ray and there's a growth plate on that x-ray. Tenderness or on necessitates a splint and follow-up Salter-Harris 1 till proven otherwise. But there is a little subtle abnormality on this one as well. You can probably see it here. What this is, you look at the lateral, a little bit more apparent. A torus fracture, so a fracture pattern that we're not going to see in adults, but we do see it in the pediatric skeleton. Another one is a green stick fracture, again, breaking half the bone, really hard to do with fully formed bones in the adult skeleton, but easy to do in the pediatric world. Another mention here, important from an emergency care perspective, is this fracture pattern that we see. You can see the subtle lines here. Hopefully they're coming across on your screen. A toddler or spiral fracture. Now, I've always been confused about, is a spiral fracture concerning for non-accidental trauma? Well, it turns out that toddlers routinely get this injury when they're toddling around. Basically a planted foot twist. Their bodies are bigger, upper torso. It's easy to get this injury. However, when we're seeing this in other bones or in kids who aren't toddling, that is always a concern. So if you're seeing it in the upper extremities, you're seeing it in the upper legs, particularly in a child who is not the right age, or if there's any concerning elements to the story, that's when you want to raise that and at least have that consideration. So looking at our fracture patterns as a whole, a couple of that we spoke about in regards to pediatric injury patterns, the spiral, torus, and green stick. Also, that Salter-Harris, high-grade Salter-Harris can lead to an impacted fracture. Important to know the language, again, to speak with our consultants. So let's transition. We've covered some of the basics. We've covered Salter-Harris 1, always the need for splinting and follow-up if there's tenderness over that growth plate. We've covered a real area of treachery, that is the supracondylar fracture, and also in adults with the elbow. Pronation, supination, super helpful exam adjuncts. Make sure that you're treating conservatively. They may very well need a sling and follow-up, possible occult injury to the radial head. Now let's get into a couple of cases from EDs that I've seen over the years. And again, predicating on this I've made every single one of these pitfalls myself. And I'll tell you specific cases where I personally have made the same or similar pitfalls. So this is around a 60-year-old female, comes in with a trip and fall, right knee pain. Of course, no closed head injury, loss of consciousness, syncope, prodrome, important questions that we ask. And there's no other trauma of injury other than the knee. So what did the exam show? Some swelling, some decreased range of motion, pain, diffuse tenderness, and an important part of this exam is the ability to extend. And I can tell you, this is an area that I have missed, where we need to check, in addition to x-rays and the bony skeleton, we need to assess the soft tissues and the tendons. Really subtle, easy injuries to miss. So you always want to extend that lower extremity to make sure that the patellar and quadriceps tendons are intact and functioning. And of course, when it's an ankle injury, we want to look at that Thompson test to make sure the Achilles is working. So in this case, an x-ray was ordered. What did the x-ray show us? So subtle, let's have radiology look at it. I'm not sure if I see anything definitively. What did radiology say? They said no fracture seen. Patient was getting ready to go home, but what happened? So immobilizer, crutches, plan for orthopedic follow-up, all reasonable. Nursing note said moves and able to leave the ER independently. The key question is what does independently mean? Does that mean independently in a wheelchair? Does that mean independently on crutches? Or does it mean being able to weight bear and transfer on that lower extremity? It turns out in this particular circumstance, the patient had a tremendous amount of difficulty weight bearing and transferring on that injured leg. Really important point. I vividly remember a patient during my training at San Francisco General Hospital. At the time, I was doing a trauma rotation there. Gentleman was sitting in a chair, complaining of knee pain, got images, no fractures identified whatsoever, but he got up to stand and said, I cannot place any weight on my leg. So me being frustrated, I said, fine, we'll just get a CT. What did the CT show? It showed a plateau fracture. Very apparent. Listen to your patients when they're unable to weight bear, they're unable to transfer, specifically with axial loading in the lower extremities. Doesn't always mean a CT. It means it's something that we need to pay attention to. So what happened in this case? The patient had some difficulty weight bearing, followed up with ortho. They obtained a CT. What did the CT show? Very clear fracture. Going back to the original x-ray, you can see that fracture pattern here. So it was even missed by the attending radiologist. Again, after the fact, the retrospectoscope is always 100% clear. It's pretty apparent looking at it now, but it was missed by a musculoskeletal radiologist. And it just emphasizes the point that putting in that clinical correlate, what I frequently do when I have a clinical concern for a fracture is I actually proactively call the radiologist to discuss the read. I see your read's negative. Did you really check the base of the thumb? Because clinically, that's what I would be most concerned about. And I can tell you there's a significant proportion of the time where x-ray reads, they say, now that you say that, it does look a little abnormal. And why don't we just go ahead and call it possible fracture, treat them as you were going to treat it. At the end of the day, we go ahead and carry out our treatment as we're going to treat them, put on the splint, have follow-up as you would otherwise. So the pearls here: review all films, discuss and document your review, document the ability to extend, look for those occult tendon injuries. I try to instill this in my brain. I've tried to do it so many times, but I still miss this at times where I see a knee injury, I see an ankle injury, I am not documenting ability to extend, looking for occult quadriceps or patellar injury, and I'm not documenting a Thompson test, looking for that posterior Achilles type of injury. And also document ability to bear weight bear and transfer, and always realize that the inability to bear weight is always a red flag, even if your radiograph is normal. So severe pain with weight bearing is concerning. Here's a picture of the Thompson test. Here's a shameless plug for my Twitter handle. I showed this just recently, a couple of weeks ago. I only have 53 tweets. Dr. Fairbanks tells me I need to tweet more frequently to kind of be more of a Twitter player. But this came from EM Conference at JD there. When evaluating acute lower extremity traumatic injuries with a negative x-ray, if can't ambulate in considering PT, we now have PT in the ED. It's a fantastic thing. Doesn't mean you always need to do a CT, but that's something that always goes through my mind. If I can't ambulate somebody and I'm calling a physical therapist, it might be well and good that there's no bony injury, but let me just make sure in my mind I can convince myself that there's not an occult fracture that wasn't picked up with the radiograph. So moving on to the next case, this is what I call the forest for the trees. So this is an 80 years old female, somewhere in her 80s, transferred to the ED from a skilled nursing facility, complaining of left knee and overall leg pain. Physical examination, low-grade fever, I believe it was 37.4 or thereabouts, a warm knee, quote unquote, and a little bit of calf pain. And so the medical decision-making was maybe this is a DVT, maybe this is some type of inflammatory arthropathy. There was no report of fall, no report of trauma, no report of injury. But the real issue here we'll get to. So the sonogram was negative for DVT, all very reasonable. The disposition, at the end of the day, the patient was not looking great. And it was felt that she couldn't go back to the skilled nursing facility, so admitted for observation to the hospitalist service with a diagnosis of low-grade fever and arthropathy, likely needs further workup, probably not a septic joint at this point, but orthopedics and perhaps rheumatology will get involved. Real case. So the nursing notes. The nurse noted that when they were utilizing the bedside commode, that the patient had a significant amount of knee pain when ambulating. Again, gets back to the principle from the prior case. Difficulty weight bearing, difficulty transferring, occult injury until proven otherwise. And another major red flag is the patient couldn't give us a full history. They were oriented to self only at baseline. So really we had limited spokes of information, not a nuanced history. All we knew is when they got out of bed to use the bedside commode, it really hurt them and they were wincing in pain. So what happened in this case? Patient was admitted. Rheumatology was consulted. What does any good rheumatologist, orthopedist do on day 0 of care? They order an x-ray. So here's a picture of the x-ray. So I want you to take a look at this x-ray, just soak it in for a minute. If anyone wants to, I know the chat hasn't been too active. I haven't been doing my job well. If the chat's not active here, does anyone see any abnormality on this x-ray? And I'm telling you.
Proximal femur.
All right.
Wait, sorry, distal femur.
All right, so some abnormality there, but I'm purposefully kind of like tricking you on this because I'm not showing you the full picture. Here's the rest of the x-ray. So this was the x-ray, and you can understand that rheumatology was they were completely upset by this. The ER missed this fracture. And I can tell you, I was running through my slide deck last night in preparation. My 7th grader walked by and he's like, ooh, Homer Simpson. And he looked at the radiograph and goes, ooh, bad break. So this isn't easy. It's not a subtle break to pick up. But the point is, and here's the lateral film, the other view, the pearl is that the only fracture you are sure to miss is the x-ray that wasn't ordered. And I always channel Joelle Bohart with this, and Joelle says it best, that just get the x-ray when you're concerned. It does add a little bit of ED time, no question, a little nursing time to get the patient over to the radiology suite. But at the end of the day, if it's an area of concern, it's a pretty low invasive test to order when you have any concern about the possibility of fracture. And I'll get back to a case that I had, and this was in my first few years as an attending. It was at Georgetown Hospital. I was working, it was a busy shift, trying to motor through and trying to, decrease the load in the chart rack as best I could. And I had a patient who was in the hallway right by the area where I was working. I examined her after an auto accident, low speed, low impact. She said her arm went up like this and hit the steering wheel during the impact. No head injury, no neck or spine injury. Everything was benign. She was safe to go home, felt a little better with Motrin, but she was left-handed and she was complaining of left arm pain. Benign exam on when I mashed everywhere. But when we went to discharge her, she kept on telling me, I think something's wrong, doc. I'm like, no, just reassurance. You're good. You're completely fine. If there's any issue, just follow up with your doctor, follow up with an orthopedist, just for good measure. But I really don't think anything's broken. My exam tells us that there's nothing broken. And I've been doing this exam for X number of years. Sure enough, she goes to sign her discharge paperwork with her dominant hand, which was her left hand. And she's like, doc, I can barely pick up this pen to sign my name. And I said, Same situation as San Francisco General several years earlier. Someone questioning me in my clinical judgment, I'll just do the x-ray. Well, it turned out she had a nightstick fracture, complete break in her ulna in the forearm that required no reduction, but it did require orthopedic follow-up and a splint, later a cast for 4 to 6 weeks. So one of the pearls here is just order the x-ray if you're concerned. Make sure that you listen to your patients. If your patients are telling you that they are having trouble weight bearing or transferring, if they're telling you I'm having trouble with pronation, supination, I'm having trouble when I'm holding a pen, that is a red flag. And I've been amazed and surprised time and time and time again at subtle clinical presentations for fractures. Another case I saw, brand new attending, my first year out, same place where Salter-Harris 1, I'm like, wow, so easy. Salter-Harris 1, tender, splint, ortho follow-up. Easy. Same as putting in a Foley catheter in terms of doing follow-up. Saw another case, it was a woman in her 50s who came in after a running injury. I think she fell while she was running or tripped when she was running, was able to weight bear and transfer, but she's like, you know, doc, I know my body well. I run on a regular basis. Something is wrong. And I did internal and external rotation, flexion, extension of the hips, and, mashed on the pelvis. I'm like, really, there's nothing wrong. There's a lot of radiation. If we do a pelvic x-ray on you, I really don't think it's warranted. Opted not to do the x-ray. And of course, a couple of days later, she comes back. She's like, I know my body. I'm still in pain. One of my colleagues saw her, and she had a chip fracture in her pelvis. Non-operative management, but she was quite upset that she didn't get that information on her first visit. So something to always keep in mind, fracture presentations, depending on someone's pain threshold, can be quite subtle. So the only fracture that you're sure to miss, the x-ray that wasn't ordered, the general rules, the lesson to be learned, orthopedic specialist, bone broke, just fix it. Emergency physician, if the bone hurts, just get the x-ray. I think it's a great lesson to follow up. And further, doubling down on that, get the x-ray and speak with the radiologist. Let them know what you're seeing clinically, because that could have a major impact on their read. And also look at all these x-rays yourself. The one thing I've noticed as I've advanced, in my seniority as an emergency physician, I now have to take off my glasses to look at those x-rays, but every MSK x-ray, I really scrub and I make sure I'm scrubbing those areas where I know a patient is tender and or I know are the biggest pitfalls from an emergency care perspective, whether it's that supracondylar, whether it's various hand injuries, etc. So now we'll get to our bonus case, case number 5, our last case that we're going to cover. So this is a 6-year-old male at the playground all day with vigorous activity. Next morning, awoke, refusing to walk. Cries when weight bearing and wants to be carried. So really not typical or routine for this 6-year-old. Discussed with the parents, and they said they're not acting like themselves at all. So pain in the left leg, in the exam, it just hurts everywhere. You really can't even do a good exam since they're so uncomfortable. Oh, and by the way, they had a low-grade fever at home, but all the other kids in the house are sick and they're at school and everyone at school is sick. And he has URI symptoms as well. So, I don't know what to make of that, whether that's pertinent or not. But doc, I just wanted to let you know that as well. So what's your differential? And most importantly, what is your approach to caring for this patient and his parents? Do you image? And if you do image, when the entire leg hurts, where do you drill it down? Do you order a pelvis, a hip, a femur, a knee, a tib fib, an ankle, and a foot for good measure? Do you ask for kind of like a leg gram in a 6-year-old, as much of that as they can capture, maybe in a couple different cartridges? And also, could this be referred pain from somewhere else? Is there something else going on in the pelvis, in the scrotum? Is there something else going on that's causing this pain? And how do I treat it? What's the best method for treating this? And what labs, if any, do I get? So the reason why we get concerned, particularly in this age group, is septic arthritis and comparing that with toxic synovitis. So septic arthritis, we all know, hematogenous spread, bacterial process, significant downstream morbidity, really destroys joints. You contrast that with toxic synovitis, which typically is post-viral, 3 to 10 years old, boys greater than girls, and it's an inflammatory process with spontaneous resolution. So really not a big deal and doesn't carry the same morbidity and mortality. So what else did we see in this particular case, and how can we utilize this clinical information to inform our decision making? And that's really the crux of this case. So PO temperature, 38.7. So not a low-grade fever. This is a real fever. The x-ray was normal, but what did we x-ray? Turned out in this case, kind of x-rayed the upper leg down to the knee. That's where best we could tell on the exam. But keeping in the back of the mind, well, if everything's negative there and we're still not getting to an answer, we might need to go a little bit more distal in terms of our radiographs. What did the lab show? We'll talk about why these labs were ordered. The white count, 12.5 with a slight lead shift. The SED rate, pending. I don't know about your entity where you work, but I have found at every entity where I've ever worked that ESRs take a really, really long period of time to result. Contrast that with CRPs, which tend to result pretty quickly. The CRP in this case was 30, the reference range being 0 to 3. And you'll notice I have milligrams per liter. This becomes very important when we look at decision rules. So what do you actually do in this case? The reason we need to pay attention to this is, again, one, ruling out a septic process, and how we can pay attention to this is through a retrospective study that was prospectively validated, done by Dr. Coker in 1999. And he found, pediatric orthopedist at Boston Children's, found that 4 factors, when combined, were highly predictive of a septic process over transient synovitis. And those 4 factors, number 1, refusal to bear weight. Again, most kids that are coming in because they're having trouble bearing weight. So this one is kind of like the point that almost everyone that we're utilizing this prediction rule for has a plus for. So fever greater than 38.5, that's how it was defined in the retrospective analysis and the prospective study, so the derivation and then the analysis phase. White count greater than 12, a SED rate greater than 40. But remember, at most sites, SED rates aren't quick to turn around. We don't get that as quickly as we get the white counts. So they added, through new literature, new research that you can see referenced here in 2006, a 5th factor, which is a CRP. The reason why this is important is if you read the study and you read the associated literature, it talks about 2 milligrams per deciliter being the cutoff for an abnormal CRP. But remember that our CRPs in our health system are not per deciliter, they are per liter. So really that equates to 20 milligrams per liter. That's what we're going to see. So a CRP greater than 20 equates to what they were talking about in the study. So emergency physicians, we love negative predictive values. This is like the best thing. Like I always say, like we don't play to win, we play not to lose in emergency medicine. We're looking to rule out the bad things. So what Coker did in his studies, he looked at patients with an acutely irritable hip. What Baer did in his study, which was more recent, he looked at patients who underwent joint aspiration. So if we look at the incidence of disease, who had septic arthritis, it is no question that the current study, and this comes from Baird, a lot more patients had septic arthritis. Why? There's selection bias. These are the ones that went for joint aspiration. But I think what's most helpful to us are Coker criteria, and these are patients that presented to the emergency department for evaluation. And so it's more of an all-comers type of picture. And what you can see here is if you have 0 or 1 factors, remember, most of our patients are going to have 1 factor at a minimum. The fact that they are having pain and limping, and that's why they came to the ER, your chances of having a septic joint are really, really low. That's what we like to see. But once you get up to 2 factors, it's a coin toss. You get to 3 or 4 factors, it's actually quite predictive of having a septic process. So how do we synthesize all this information? How do we put it together? Couple of things that are important to keep in mind. First and foremost, I have no financial relationship with MD Calc, by the way. I'm just a vigorous consumer of MD Calc. I think it's really, really helpful at the bedside. Not only does it allow you to calculate the number of criteria and making sure you're using the right criterion for each step, but it also gives you something called Creator Insights, where you can read further on your downtime and look at what the creator says. And they actually interviewed Dr. Kocher by MD Calc. They have an interview and they have responses to questions that were submitted, and he gives those answers. So first and foremost, can you apply these criteria to joints other than the knee? Because a lot of people do. They say that, other than the hip. So it was developed for the hip. Can you utilize it for the knee? or other areas. We're seeing more and more of Lyme arthropathy. Again, is it a septic process that's bacteria? Is it a Lyme process? A lot of questions arise in pediatric emergency care. What Coker says is that this was developed for the hip. I don't recommend utilizing this for other joints because we haven't studied it as of yet for any other joint. So it's really focused on the hip. What about the CRP question instead of the ESR? Coker did the original study. Bayer did an update study, similar prediction performance with CRP and ESR, so we can use them interchangeably. We're allowed to use that CRP greater than 20, meets the criteria to get a point on our scale. So how does Coker actually use it? And they asked that question, and you can look it up in MD Calc, and I believe it's free on the web. How does he use it? He says what he does in his practice at Boston Children's is a routine ultrasound of the hip in the ER. Basically, if they have any of the criteria, if there's an effusion and there's a risk profile, meaning more than 1, 0, 1, 2, or further on that scale, he recommends aspiration. Who does the aspiration? Orthopedics or interventional radiology. Those are the two key services that will perform it. But what he says further is if there's no effusion on ultrasound, even if I'm concerned, I engage the consultant, in which case it's me as a pediatric orthopedist, but at the end of the day, we're probably not going to do anything other than watch because we can't tap a dry joint if we're not seeing an effusion on ultrasound. So I think this could be helpful for us in the ED setting, just incorporating ultrasound into our decision making. But again, this is never a decision that we're making in a silo in isolation. We're engaging our orthopedic consultants. So Coker criteria, how do we synthesize this information? Reasonable negative predictive value. The more factors among those factors, the higher the positive predictive value, but place it in the clinical context and speak the language of our consultants. Whenever I have these cases, not too frequently, but I actually talk about the Coker criteria when I'm having that conversation. Now, in terms of treatments, perhaps the best advice I have ever heard came from Dr. Rick Place, who is a pediatric emergency physician at Fairfax. We know him very well. Our residents spend some time at Fairfax on the pediatric unit there in the pediatric ED. We've done a lot of academic collaborations with Dr. Place and his group over the years. I heard a lecture by Rick at some point years ago, and the question of septic arthritis versus transient synovitis came up. And Dr. Place, he trained, he was like a PGY 10 in training. I believe he did pediatrics first. Then he did an adolescent medicine fellowship in pediatrics. Then he did a 4-year EM residency. So 10 years in the trenches. What he said, how he synthesizes all this information, whenever he sees a kid with a limp that falls into this age range, he immediately gives them, like even if they're in the triage area, a healthy dose of ibuprofen. So a true dose of ibuprofen, 10 mg per kg. So how much is this in a 6-year-old? Getting back to what we talked about before, maybe they're 25 kilograms or so, but make sure you weigh them. Make sure you do a fact check to make sure it's not a pounds, it's actually a kilogram weight. So they're going to get somewhere between 200 and 250 of Motrin, but a true 10 mg per kg. And he lets them wait until they get back. Sometimes with that good, healthy dose of Motrin in and of itself, in the case of transient synovitis, kids are running around within an hour. So important thing to keep in mind. I've definitely incorporated that in my practice. I think it's really, really helpful when kids get better. Not all of them do, and then you continue to march down that pathway. But if they're no longer having any pain, it's really helpful for making those clinical decisions. So we'll go ahead and round it out with some conclusions. This is my very favorite cartoon from the New Yorker. You can see the quotation says, next, an example of the very same procedure when done correctly. It doesn't look too good for the person who's being rolled out, and you can see the word look on the gentleman coming in. So let's see if we did things correctly here. So what are our radiological and peds ortho pearls? First and foremost, tenderness over a growth plate, Salter-Harris 1 until proven otherwise. The peds elbow, an area of treachery. Look for the figure of 8. Look for anterior, posterior fat pads. Again, anterior, if it's hyper, if it's bowed out, is abnormal. Posterior is always abnormal. The anterior humeral line, the mid-radial line, and then scour for fractures. really keys to evaluating the peds elbow. For adults, always be mindful of that occult radial head injury. Again, what do we do for radial head injuries? We put them in a sling. We have them follow up with MSK or ortho. At the end of the day, not a big deal, but it's something that we at least want to communicate that with our patients. Our concern regarding that possibility, if the x-ray is normal, pain with pronation and supination. Peds, unique bony injury patterns. We talked about torus, we talked about green strick, we talked about that impaction, which is a Salter Harris 5, which is really a significant injury. Think about the tendons in your adults. Quadriceps, patellar, Achilles, really important things to document. Every knee that you see, oh, it's just a sprain, but did I check the tendons? Ankle I see, x-rays normal, probably a sprain. Check the Achilles tendon. Feel it, utilize the Thompson test, and for the quad and patellar, make sure they can extend that leg. The inability to bear weight is always a red flag. If you're thinking PT, they just are having trouble with mobility, just think to yourself, if there's a traumatic injury, they're having trouble weight bearing or transferring, could there be an occult injury? Important thing to keep in mind. We don't always do the CT, but we just at least need to think about it, address what we thought about in our documentation, and make sure that we're ordering the appropriate things before dismissing. Because I can tell you in my career, I've dismissed more things than I care to admit that I said couldn't possibly be a fracture. Turns out that they were fractures. The fracture you were sure to miss is when you don't get the x-rays, so have a really low threshold for x-raying. And again, know the Coker criteria, really helpful. Utilize MD Calc, speak the language of our consultants. So I'll go ahead and pause there. Again, what I always like to say is in emergency care, we don't play to win, we play not to lose. And so hopefully this provides some good reminders and pearls to help us all play not to lose. So with that, I'll conclude. And Manish, I'll turn it over to you. Thanks so much.
John, thank you. That was outstanding. We do have a question in the chat about CRP. It is high sensitivity CRPs. Are they the same as a regular CRP?
You know, that's an excellent question. I am not sure of the answer to that. I know it can be ordered in 2 different channels, but it's certainly something that I can follow up with the group, but it's a great question. If anyone else knows the answer to that offhand, please chime in.
John, high sensitivity CRP is more used for cardiac and stroke, and regular CRP is more used for infection. So the scales are different. So from an infection standpoint, you just order a regular CRP. So like an MSK infection, it'd just be a regular CRP.
Great. Thanks so much, Liz. That's great.
And 2 great pearls shared from some of our colleagues. Dr. Sheehan says any displaced Salter Harris fracture has to be seen by ortho in the emergency department. And Dr. Dallas-Ibera says that ensure you get the sunrise view for patients with knee trauma, as you might miss a patella fracture on standard 3-view imaging. Important to note that the standard preset imaging we have for knee imaging does not include a sunrise view. All right, with that, I think we can wrap up the morning Fall Symposium. 2 hours of really high yield education, leveraging the expertise that we have in our group. I want to thank all the speakers, John Davis, Jon Watson, Katie Voss, and all of you for attending. We'll